screen now?
Yes, it's visible.
You can see the presentation?
Yes, it's in full screen now.
Thank you. So our topic today is about blistering disorders. Blistering disorders is a big topic. It involves many or lots of categories of things that could cause it. Some things are common and we're like almost everybody is familiar with it, like burns, and some are rare. We see it mainly in dermatology clinics and specialized dermatology clinics, like some of the genetic disorders or genodermatosis that present with blistering. So let's start our presentation now. These are the learning objectives from today's presentation. First, to identify and differentiate between blisters and vesicles and the types of blister, whether it's tense or flaccid, and how it correlates histologically with the degree of separation on the skin layers. And the second thing is to develop a structured approach to the differential diagnosis of blistering disorders, and to identify the key clinical and diagnostic clues and different diagnostic tests that we do for different blistering disorders according to the top differential. And in some of the disorders, I will discuss the initial management, and what I will discuss the emergencies, which ones that needs to go to emergency for urgent management, which ones are life-threatening, which ones can be managed elsewhere. So this is a general definition. So blistering disorders involve fluid accumulation within or beneath the epidermis. We have vesicles, as we said before, and bulli. The vesicles, they are small blisters that are less than 5 millimeter in diameter, and the bulli are 5 millimeters in diameter or larger than that. Blister is a general term. So usually in dermatology, we say vesicle or bulli. It depends on the level of epidermal separation. So flaccid blisters, the level of separation is intraepidermally. So it's at the 4 layers or 5 layers of epidermis, depending on the site because it's 5 layers in some places and 4 layers in other places. So the flaccid blister, they rupture easily, and they will show you later in next slides how they look clinically, and they leave erosions. So some of the diseases that are associated or that present with flaccid blisters, you might not see the blister, you just see the aftermath or the ruptured blisters leaving a denuded or eroded skin. Then we have the tense blisters. The tense blisters usually arise from the subepidermis, the separation in the subepidermal layer. So usually you can see them. Sometimes they rupture and erode, but most of the times it is visible, and patient can tell you most of the times that there's a blister. There is an exception to this rule. Flaccid blisters, if they present in thick skin, meaning the acral areas, they can present as tense blisters, although the separation is intraepidermally. But because of the thickness of the skin, they look as tense. So for the healing for intraepidermal blisters, the intraepidermal blisters, they rarely scar. They usually heal with normal skin, or according if they are infected or not. If they are infected, they might leave dyspigmentation or scarring. But the subepidermal blisters, most of the time, they heal with the scarring or pigmentary changes, hypo or hyperpigmentation. And some of the diseases, they heal with melia. And I will show you examples of these. So this is an example of a flaccid blister. These usually rupture quickly and we see the erosion. And this is an example, the one on the right is an example of a tense blister. And if you can see here, there was in the black arrow, there was a tense blister here and it healed. And as you can see, there is small melia structures. This is one of the process of healing in the subepidermal or deep blisters. So these are the some of the healing types. The first picture is healing by scarring, the second with dyspigmentation mainly, and the third, as we discussed just now, healing with melia formation. For the classification of blistering diseases, especially histologically, we depend on the level of separation or level of the fluid accumulation. If it's very superficial, which is subcorneum, it's below the stratum corneum. We call it subcorneal bully. The differential include bullous impetigo and staphylococcal scalded skin syndrome and some of the pemphigus variants. For the intraepidermal bully, there is the differential of viral vesicles like herpes infection, and also some of types of pemphigus like pemphigus vulgaris, and incontinentia pigmenti, which is a genetic disease. And then for the subepidermal bully, we have lots of differential, including the common one is bullous pemphigoid, dermatitis herpetiformis, and some of the drug or infectious related process, autoimmune process like erythema multiforme. And also some of the genodermatosis, epidermolysis bullosa, some of the types, or the types, there are different types, and they occur at different levels of separations. One of them is dystrophic, it's deep type, and it occurs in the subepidermal, and it's associated with subepidermal blisters. So these are general causes for blistering disorders. So when we say blistering disorders, it doesn't mean one entity. So it can, genodermatosis, some genetic diseases can present with blistering. Some infectious diseases have, they present with blistering or have variants that present as blistering. Also, there is the autoimmune blistering diseases, which is most commonly discussed by dermatologists. That include pemphigus and pemphigoid, and also inflammatory disorders like the small vesicles in a general term eczema, or an atopic dermatitis, or any dermatitis. And also we have drug-induced like Stevens-Johnson syndrome, and we have those associated with systemic disorders like porphyria cutaneous terata. And we have mechanical or physical blisters, which are the most common ones. And I'm sure everybody has encountered someone with these, like the blister, the sunburn blisters, the burn blisters, the friction blisters from ill-fitting shoes. There are many of them. So we'll move on to each type or each variant, each cause, I mean. Can you see my screen? Sorry.
أيوة دكتور الآن واضحة.
So first one is genodermatosis. One of the examples of genodermatosis, I put the picture here. It's called incontinentia pigmenti. It's basically let's talk about it in the next slide. But keep in mind that this is a picture of a newborn with these linear blisters. So the most common genodermatosis with blistering is epidermolysis bullosa. We have many subtypes of epidermolysis bullosa according to level of separation. So there is epidermolysis bullosa simplex. It's a more superficial level of separation. It's within the epidermis. Then there is the junctional epidermolysis bullosa, in which the separation is at the lamina lucida in the basement membrane between the epidermis and dermis. And there's the dystrophic epidermolysis bullosa, which is below the basement membrane that separates the epidermis from the dermis. And there is a syndrome, it's called Kindler syndrome. There's no special site of separation, but there's mixed levels, and it usually occurs early on in life and changed with aging. So these are the most common one, and they're usually they're different. Some of them are autosomal dominant, and some of them are autosomal recessive. Some of them are only acral, so they occur only on the hands and feet and elbows and knees, and some of them are more generalized and involve even the mucous membranes, and it's a heterogeneous group, and the presentation is different, and usually the diagnosis is done by taking a skin sample for electron microscopy to see the level of separation. The first picture is of acral epidermolysis bullosa simplex. It usually occurs, it's a mechanic blister, so at sites of friction, as you can see in this newborn. The second picture is an extreme presentation. It's a epidermolysis bullosa dystrophica, the third variant that we just discussed. And it can lead to this deformity. So as you can see, the presentation is heterogeneous depending on the level of separation. If the level is higher, usually the blisters or the presentation is different from the deeper ones, like the dystrophic one. There is also some of the genodermatosis that present early in life. So some of the genodermatosis that presents early on, meaning in infancy or in neonate period, is incontinentia pigmenti. It's a disease that has 3 to 4 stages. The vesicular or blistering stage is the first stage, and it's usually in the first few weeks of life. The patient presents with linear vesicles, then heals in a few weeks. Then later, the same patients, they can develop hyperkeratotic plaques. Then later they develop hyperpigmentation. So we don't know at which stage we see them. And the last stage is hypopigmentation, but not everybody gets the last stage. So sometimes they present to us with the hyperpigmented lesions, and so it's important to ask about the previous history if as a neonate or an early infancy the child has vesicles or blisters over any body sites. And this incontinentia pigmenti is an X-linked dominant. So male fetuses, they don't survive. So we usually see it in female. The second diagnosis with early presentation, it's epidermolytic ichthyosis. It's a keratin mutation. And the patients present with skin fragility and blistering early on in their life, in the neonatal period and in infancy. Then it improves in childhood and almost disappears. There's no blistering in adulthood. And the third one, it's not a genodermatosis. It's called congenital syphilis, but it is due to syphilis. It's not a genetic issue. But I put it in with these because it presents in the neonatal period. So usually it occurs in the palms and soles and presents with tense hemorrhagic bully. So we need to ask further history about any deeper involvement. We investigate for deeper involvement, like hepatosplenomegaly and bone changes, and we ask, we take the history from the mother as well. Then these are genodermatosis, and they can have blistering, but they present late in life. They present in 20s to 40s usually, and these are Hailey-Hailey disease and Darier's disease. So Hailey-Hailey disease is primarily present with erosion and flaccid vesicles over the flexures. So armpits, inguinal area, flexures, these are the common sites for it. And I have a picture here. Yeah, this one in the armpits for Hailey-Hailey disease. And I put Darier's disease, although the common presentation is not blistering, but there is a very rare variant, which is called acral hemorrhagic variant that presents with blistering over the palms and soles, as you can see in this picture. It's a hemorrhagic blisters. So that's mainly about the genodermatosis. Do you have any questions that we can answer? Okay. Then we'll proceed to the infectious. Infectious causes of blistering includes viral infections, bacterial infection, fungal, some parasitic, and also arthropod related. Some of them primarily present with vesicles, and some of them it's just a variant of presentation. So like the most common variant, the most common presentation is not with blisters, but they can present with blisters. So for the viral, the most common one is the herpes simplex, whether it's oral herpes, genital herpes, or generalized herpes. And also we have the varicella infection and the shingles, herpes zoster infection. And these are the most common one, and we usually see them and manage them with antiviral. And then we have the Kabushi varicilliform eruption and eczema herpeticum. So the Kabushi varicilliform eruption is a disseminated it's an infection by herpes simplex viruses 1 or 2, and it occurs on top of abnormal skin, right? Like patients with atopic dermatitis, we call this eczema herpeticum or Kabushi varicilliform eruption. So it's an herpes simplex virus infection on top of abnormal skin. And it is considered emergency and needs the patient needs to take acyclovir. Hand and foot mouth disease. It also has 2 variants: typical variant and atypical variant. The typical presentation is vesicles or papules on the palms and soles, and also in the oral mucosa. And the atypical presentation can be more extensive, similar vesicles, but it can be more extensive, like beyond the hand and feet and mouth areas. And RF, we usually they see it, and it's a self-limited actually, or RF, and it's a viral infection that usually we see it around Eid al-Adha. because of the contact with the sheep. Then we'll move to bacterial infections. Bacterial infections is one of the most common one is bullous impetigo. There are two types of impetigo. One of them is bullous impetigo, presents as blisters or bulli in especially in lower trunk area and periinguinal area and proximal extremities. We can take a swab for that to see to ascertain the diagnosis. The other thing is the staphylococcal scalded skin syndrome, and it's usually present with a very superficial blistering or erosions, and it is an emergency that needs to be managed, as well as air spills and cellulitis. They don't usually have blister. They don't usually present with blisters, but they can have certain variant that has like a bully because of the severity of inflammation. There's a Vibrio vulnificus hemorrhagic bully that usually occurs in the acral area, and I have a picture for that I will show it later. Also meningococcemia, which is an emergency. It can present with blisters from the severity of inflammation. And also we have anthrax. Fungal infection, most tinea pedis is it has variants, most commonly the interdigital variant with whitish plaques, but some patients can get this vesiculobullous variant of tinea pedis, which presents as vesicles. Also, other fungal is, it's not a true fungal, but it's a reaction to fungal with a dermatitis-like, and it's called ED reaction. We have also a bed bug bites reaction. Some of the bed bug bites, if it becomes, or arthropod bites, becomes inflamed, and with the severity of inflammation, blisters develop. And usually they are very, very itchy and in exposed areas of the body, and sometimes they are near each other or grouped. So this first picture on top, it's a picture of Vibrio vulnificus hemorrhagic blister. And the second one is dermatomal distribution with blistering, which is characteristic of, or which is diagnostic for shingles. And the third one is the one we discussed now, the tinea pedis. It presents in the foot and with blistering. This is a vesiculobullous variant of tinea pedis. The last one is herpes simplex genital infection. Usually they have more of a scalloped border, but you can see these erosions that was a flaccid vesicle that ruptured. Now we're done with the infectious causes. We'll move on to the autoimmune blistering diseases. We usually say pemphigus group or and pemphigoid group and dermatitis herpetiformis. So there are many blistering diseases and many classification of the blistering diseases, but today I will discuss just the most common ones. So the first one is pemphigus vulgaris. Pemphigus vulgaris is usually mucosal, so you have to examine the oral mucosa, and usually this is the most like severe complaint is the oral involvement and inability to eat and pain associated with it. And also a good number, they have also a skin involvement. As you can see, we're discussing a blistering disease, but you don't see a blister here, but there was a blister that ruptured and left erosion. So for diagnosis of superficial blistering diseases that is involving the very superficial layers of the epidermis, you might not see, or most of the times you don't see a blister, you just see the erosions. So put it in your mind that this could be a blistering disease. So usually we take to diagnose this, we need to take biopsies. We take a biopsy for H&E, as you can see the picture in the middle, showing the separation in the epidermis. And also we send for direct immunofluorescence for depositions of immunoglobulins and complement to fully diagnose the patient with specific blistering diseases, because different deposition is associated with different diseases. For example, if the deposition is mainly IgA, we think about IgA pemphigus, which is a variant of pemphigus. If it's C3 IgG, we think about pemphigus vulgaris. And the picture below is of bullous pemphigoid. So as we discussed, bullous pemphigoid level of separation is deeper than pemphigus. So you can see the blisters are flaccid, are tense. So you can see them, they're shiny, tense blisters. And you can see in the pathology that the whole epidermis is separated, not inside the epidermis, but the epidermis is separated from the dermis in this picture in the middle. And this is the immunofluorescence pattern. We call it, it is, if you can see, this is the basement membrane zone that has the fluorescence. And it's usually of IgG and complement C3. So brief about the most common pemphigus and pemphigoid diagnosis. First is pemphigus vulgaris. So it's an autoimmune blistering disease with desmoglein 3 and desmoglein 1 causing a suprabasal acantholysis, meaning it's in the epidermis, the separation is in the epidermis. And they have a flaccid blisters, and they have also a mucosal involvement, a prominent mucosal involvement with oral erosions and in different parts of the mouth. So we need to examine the gingiva, the palate, the buccal mucosa, the lips, and it usually has a positive Nikolsky sign. And we manage acutely in the emergency with systemic steroids, usually higher doses of systemic steroids and immunosuppressants. And we also can give the new biologics, which is very effective. It's rituximab. And whenever the patient has a recurrence, we can repeat the same, the biologic, the rituximab infusions. Then we have the a form of pemphigus, but it's more superficial in the superficial layer of the epidermis. It has autoantibodies that target a special molecule in the upper epidermis. It's a desmoglein 1, and it's in the as we discussed, it's in the superficial part of epidermis, the cornea, stratum corneum layer. So it's below the stratum corneal layer where the separation happens. So usually we don't see blister, we just see, as you can see in the pictures, the erosions and crusts covering the erosions. Usually it occurs in this area, the chest, the back, the face, but it can occur in other parts of the body as well, but these are the common ones. And it has some variants or some forms to it. And we usually treat it with, acutely, we treat the patient with steroids, and we give a steroid-sparing agent like methotrexate. And if the patient has severe involvement, we can give rituximab, although it was not approved for it. It's approved for pemphigus vulgaris, but still we can give it, and it's very effective. Bullous pemphigoid. Bullous pemphigoid is deeper. It's not in the epidermis. It's subepidermis. It has autoantibody. It's an autoimmune blistering with autoantibodies targeting bullous pemphigoid antigen 180 and bullous pemphigoid antigen 230 that are in the basement membrane zone. So it has intense subepidermal blisters, and sometimes we can diagnose bullous pemphigoid even without blistering because there is a subset of patients who have urticarial phase, and it can stay for many months or persist, and it's very itchy. So the method to diagnose it here is to take a biopsy for H&E, and also a biopsy for direct immunofluorescence, in which we will see the linear deposition of the IgG and C3, as we saw in the first picture. And we can, according to the level of severity, we have many treatment options and guidelines, starting from topicals to systemic steroids to newer biologic medications. Then we have a variant of bullous pemphigoid that occurs in pregnancy. It's called pemphigoid gestationis. It's against bullous pemphigoid antigen 180, and it's also a tense blister that are subepidermally located, and usually in the second and third trimester, and the patients have a peri-umbilical involvement, which is a typical sign for pemphigoid gestationis. And when we take a biopsy, it will show similar findings in the histopathology, which is similar level of separation as bullous pemphigoid, and also similar. Also, the DIF has linear similar deposition of C3 mainly. And it can flare also at a postpartum period, and flares with menaces, and in upcoming pregnancies we can tell the patient that it usually recurs, and it can affect the newborn. So the newborns, for the first few months, they can have blisters from the past maternal antibodies that are passed to the newborn. Not all the newborn, but there is, I think, about 10% of them can get it. Then there is the linear IgA bullous dermatosis. It has this characteristic morphology. It can present with just blisters without this morphology, but this presentation is characteristic for it, as you can see. It looks like a flower or pearls. It is an autoimmune blistering disease with linear deposition of IgA. Unlike the others, the bullous pemphigoid, it was IgG. This is an IgA along the basement membrane zone, and it's also the same. It's tense and subepidermal blisters. And it can be like idiopathic or drug-induced. A typical drug that could induce it is vancomycin. And there is also a variant that occurs in childhood. We call it chronic bullous disease of childhood. But it has the same presentation histologically, and can have the same string of pearls presentation clinically. And DIF will have IgA deposition, and it responds. It has an excellent response to dapsone usually. Then the last common autoimmune blistering disease is dermatitis herpetiformis. It's a cutaneous manifestation of celiac disease with IgA deposition in that area. And usually the patient present with extremely pruritic vesicles on the elbows, knees, and buttock, and can be also present elsewhere, like in this patient, in the elbows and on the back of scalp, and in the occipital scalp area. And in the histology, it shows lots of neutrophils. So there is neutrophils in the dermal papillae and subepidermal macrovesicles. And when we take a biopsy for DIF, it usually shows a granular IgA deposition. Unlike the previous one, it shows a linear IgA deposition. And usually we manage it with dapsone as well and a strict gluten-free diet. Now we'll move to the inflammatory disorders. So for the inflammatory disorders, lots of dermatologic disorders could present with blisterings, and it is due to the extensive inflammation, which causes the separation. So it's not a true separation. So it's the inflammation that causes a separation because of the deposition of the cells from the severe inflammation. So this is not like all the diseases that could present with it, but these are the common ones. So we have dyshidrotic eczema. As you can see in these pictures, it usually occurs on the lateral parts of the digits and presents with the deep-seated vesicles that are very itchy. We have also allergic contact dermatitis, like patients who are allergic to poison ivy and get exposed to it. They develop severe blisters over usually the areas that gets in contact, mostly the arms or the legs. And also we have the acute phase of atopic dermatitis, in which there are small vesicles, and other diseases like erythema multiforme. It could present with one of the presentation. It presents with blisters, especially at the center of the target lesions. We have also Grover's disease that are itchy in the upper trunk of usually white men, older men. And we also have one of the variants of lichen planus. It's called bullous lichen planus. We have uncommon diseases like pleva and genetic Christie syndrome. It has a vesicular variant, Sweet syndrome. It can have like a bullous variant, and it has some associations. Vasculitis, if it's severe, with the severity of inflammation, blisters can develop within the vasculitic lesions. And there's also photodermatosis called hydrovacciniformis that present with vesicles over sun-exposed areas. There is also a drug-induced. The most common and dermatologic emergency one is the Stevens-Johnson syndrome and toxic epidermal necrolysis. As you can see here, it involves the face has blisters, the whole body presents with blistering and erosions, and also the mucous membrane are usually involved, the eyes, the nasal mucosa, the oral mucosa, and the genital mucosa. And we have also bullous fixed drug eruption. So it's a reaction to one of the medication that presents with, that has many variants. One of them is bullous, and sometimes it is a severe one when it becomes like a generalized bullous fixed drug eruption. And with the new medications, the targeted immunotherapy medications for many indications, they can present with bullous dermatosis. So this is an important entity, immunotherapy-induced bullous dermatosis. And there is also a photosensitivity drug reaction with blistering and sunburn-like, and there is many medications that can induce different types of autoimmune blistering diseases. Then we have blistering diseases that are associated with systemic disorders, like we can see here in this picture with porphyric cutana terata. And there's also blisters that occurs in diabetic patients. We call them bullous diabeticorum. And there is the last one, the physical and mechanical blistering, like friction blister. You can see it here in the over the Achilles tendon area, the back of the foot. There is a blister from a friction from ill-fitting shoe, and there is also pressure blisters and thermal burns, frostbite, sunburn. Like you can see in this picture, the patient has sunburn and blistering on top. And also chemical burns, cryotherapy related blisters, the cryotherapy that we usually use to treat wart and other dermatologic conditions, like actinic keratosis. We usually discuss with the patient that the blistering can occur with this management option. So we need to do many diagnostic tests according to our highest suspicion clinically. So we can do the routine histology from the lesion. It's better if it's a small vesicle to take it fully, or to take a part of it to with a small part of normal skin to see the level of separation. And we can do also direct immunofluorescence to see different types of autoimmune blistering disease, as well as indirect immunofluorescence and ELISA tests, in which the patient serum is added to specific substrate according to the disease we're suspecting, and it shows the antigen. And electron microscopy, especially for the epidermolysis bullosa to know the subtype. We also can do PCR for infectious etiology, like for herpes simplex type 1, to diagnose also shingles. And we also can do culture for suspecting, for example, bacterial one. We can do blood cultures, cultures from the skin, and also for back to viral, we can do Zank smear for herpes family infection. And we can do KOH preparation if we are suspecting a fungal, like the Bullous tinea pedis. And we can do genetic testing for different types of genodermatosis. And for porphyrias, we can do porphyrin studies, serum perforin, urine perforin, and stool perforin. And for allergic contact dermatitis, if that's our clinical suspicion, we always can do patch testing to rule out, to help diagnose this. And do you have any questions? I know it's a very large topic, and if we discuss all the diseases, it will need more time. But I tried to cover the most common one with some of the